You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 25th, 2025. This week, AI and ECGs, a novel way to treat hypertension, combined in early lipid-lowering therapy after MI, a move toward accountability in AF ablation, and pacing issues with transcatheter tricuspid valve replacement. First topic, help with ECG reading in the emergency department. Now, I want to say that I chose cardiology in the first place because I was enamored by ECG reading. I read ECGs at Indiana with the famous Dr. Charles Fish, and it was exhilarating. To this day, the ECG helps me understand arrhythmias in the EP lab. But ECG reading seems to have gone the way of auscultation. People seem to struggle with it. This has direct impact, obviously, in the emergency department where missed ischemic changes can delay revascularization. What I remain confused about is how AI, machine learning, hasn't simply taken over the pattern recognition in an ECG. I mean, I can have a full conversation with Claude or Perplexity about the most nuanced aspects of almost anything in the world, and we don't yet have an AI that can properly read an ECG. It's all pattern recognition. I don't get it. Now, the Queen of Hearts team have made great progress, and now a study from the group at the University of Munster in Germany may have also advanced the process of improving ECG reading in the emergency department. The European Heart Journal has published a paper, and it was a late breaker at ACC. Before I see anything, I need to set out that I am not an expert in AI-type studies, and the primary endpoint here, which was an AUROC, or area under the receiver operating curve. That's a tough endpoint. But here goes. The group first used a U.S. database of ECGs from emergency departments. They also knew how many of these patients had revascularization, so they trained an AI model on 80% of these 200,000 visits. They then test the model on 20%. The AI ECG model does well on the test cohort with an area under the receiver operating curve of 0.91. Now, briefly, on the matter of ROC curves, this measure evaluates how well the model discriminates between patients who need revascularization and those who don't. For instance, an AUROC of 0.91 means that if you randomly select one patient who needed revascularization and one patient who didn't, the model would correctly assign a higher risk to the patient needing revascularization 91% of the time. Now, this AI model outperformed clinician ECG reading, which was pretty bad with an ROC of 0.65. Remember that 0.5 is a coin flip. It also outperformed troponins, which had an AUROC of 0.71. Now, they also looked at more typical metrics such as sensitivity, specificity, negative and positive predictive value, and it was quite good there as well. For instance, a negative predictive value for rule-out of MI was 99.92%. They then did the most important thing that an AI model needs to do. They tested it in an external data set in Munster, Germany. Here, the model had a lower, but still pretty good AUROC of 0.81 in detecting patients with revascularization during the index admission. This outperformed clinicians again, who were at 0.70, but it was slightly inferior to troponins, which in Germany had an AUROC of 0.85. They also tested the model for detecting type 1 MI in the external validation cohort in Germany. Here, the AUROC was 0.85, clinician 0.74, and troponin 0.87. Finally, their machine learning model was open source, and they did something called a heat map, which helped explain how the model works. And I'm way over my skis here, but my best guess at explaining this is that they showed that the model actually looks at specific leads and STT changes, which is something different with AI models that this group actually tried to show how it works. So my comments, this is a nice start. It doesn't bother me that troponin was slightly better than the ECG model because we rely on ECGs in the first moments. Troponins are valuable, but less valuable as they take hours. Another strength of the study, the machine learning model was developed on a broad ED cohort. rather than a high-risk group of suspected MIs. Also, it's open source. Any author's attempt to show how it works is good, good, good. Literally everyone in medicine now is using AI tools to help them. If you're not using AI, you're not doing it right. ED physicians should also get the benefit of AI support. Turns out, though, it's more complicated than I had thought. I don't know that we'll ever get to the point that an AI will be able to do everything in terms of evaluation in the ER, because so often the best way to get to the right diagnosis with chest pain is to look at that person, talk to them. And that's always going to be a qualitative thing. And I'm not sure that qualitative matter will be modelable. At least I can't imagine a human-human interaction being able to be modeled, but perhaps I don't imagine strongly enough. All right, next topic, a novel way to treat hypertension. This is something I didn't know about until a few weeks ago. The FDA this week has given a breakthrough device designation status to Orchestra Biomed for its atrioventricular interval modulation, AV-IM therapy for patients with uncontrolled hypertension. Like I said, didn't know about this until recently. But it turns out that our hospital is going to be participating in a large trial of this pacing modality. AV-IM is a pacing algorithm incorporated into dual-chamber pacers that deliver repeating sequences of slightly shorter and slightly longer AV delays, which lowers blood pressure while simultaneously modulating the autonomic nervous system. The Journal of American Heart Association published the Phase 2 study of this in 2021. I'll link to it. This was a small study of about 40 patients with hypertension randomized to AV modulation on or off in a blinded fashion. And the placebo-subtracted difference in blood pressure at 6 months was 8 millimeters of mercury, though the confidence intervals were wide. The makers of this algorithm have partnered with Medtronic, and they're going to conduct this large sham-controlled international trial called Backbeat. And I will link to the clinicaltrials.gov site. That's the trial that we're going to participate in our center. Now, you might wonder how this works, and I surely did. And here's the brief explanation. AV-IM is a pacemaker-based therapy that takes advantage of the fact that 1, ventricular pressure generation is preload dependent. 2, preload can be manipulated by reducing AV pacing intervals. And 3, periodic orchestrated variations of systolic blood pressure achieved by the repeating sequences of short and longer AV intervals can suppress sympathetic activation, ordinarily accompanying reductions in blood pressure. So I used my AI model, Claude, and Perplexity confirmed it to learn what an FDA breakthrough designation means. This designation does not mean the device can be immediately used and billed for clinically. Rather, it gives the company priority reviews for the device, more interactive communication with FDA, the possibility of expedited review, and senior FDA management engagement in the review process. The device would still need to receive full FDA approval or clearance before it can be marketed and used clinically. The designation simply helps speed up the regulatory process. So, my comments, obviously, if 8 millimeters of mercury blood pressure reduction holds up, it's going to be far better than renal denervation. But obviously, this is quite early, and we shall see what the Backbeat trial finds. What's more, we don't have any information on safety, although it's hard to imagine there is a safety concern. But if this works, man, that could be pretty darn important given the prevalence of hypertension in patients with dual-chamber pacers. All right, third topic, general cardiology topic. Jack has published a nicely done observational study from the Sweetheart Registry looking at the value of early ezetimibe initiation after MI. I think it's an important question because when a patient survives an MI, the obvious goal is to prevent another one. These are high-risk patients, and heart disease, we sometimes forget, is hugely modifiable. Well known already is that statins, particularly high-potency statins, reduce outcomes in MI. Yet not all patients reach target LDL, and even if they do, there may be value in going lower with combined therapy. Also well known is that adherence to medications that don't change how one feels is kind of imperfect, isn't it? Previous studies show that adherence might be better when drugs are started during or early after a big event, hospitalization, say after an MI. We also know from the Improve It trial that adding ezetimibe to simvastatin in patients with a recent acute coronary syndrome further reduced LDL cholesterol levels and cardiovascular events compared to simvastatin alone. Now, some felt that the results of Improve It supported the lower is better hypothesis for LDL cholesterol by showing that the median LDL levels of the combined therapy, 53, provided incremental clinical benefit over the 69 milligrams per deciliter achieved with statin monotherapy. Now, the problem, of course, with Improve It was the effect size. It was tiny. The difference in a composite endpoint was 2%. Hazard ratio was 0.94. That's a 6% improvement. And the trial went on for 7 years in more than 18,000 patients. And there was no difference in death or CV death. And also the PCSK9 trials where alirocumab was added to statin therapy in post-MI patients. It was a similar story to Improve It. There were lower LDL levels and very small reductions in non-fatal CV outcomes and no difference in CV or all-cause death. Now, the Sweetheart study that Jack published is clever. It's very clever. It's an observational non-random comparison of 3 groups of more than 35,000 patients. About 17,000 who had early ezetimibe, 18% who had late ezetimibe, and 65% had no ezetimibe added to their statin. The question, of course, is MACE outcomes in these 3 groups, but they're not randomized. Now, there were baseline differences. For instance, the group on no ezetimibe were older. They had more conditions and a lower LDL cholesterol. The other problem with this comparison is the time zero issue. Different start times means that you can have immortal time bias. That is, those that start later have to survive to start later. Now, the authors know all this stuff about non-random comparisons, and they discuss it clearly in their paper. Their solution is to do something I've never heard of called a clone sensor weight combined with the inverse probability of censoring weights. I know. It's a complicated statistical maneuver that I am 99% sure I will get wrong if I try to explain it. Basically, this is a way to deal with selection bias because clinicians, not randomization, chose whether to start or not start early or late ezetimibe. Here's a brief explanation. For each index MI, 3 clones were created corresponding to each treatment strategy. The group then assesses whether a clone adheres to the strategy. For example, if a clone assigned to the no ezetimibe initiation within 12-week strategy began treatment at 6 weeks, it was censored at that time. This, of course, is informative censoring to adjust for potential selection bias due to informative censoring. The group applied weight models based on the probability of informative censoring. Now, I'm going to stop there before I screw it up and bore you. From a non-expert in statistics, it seems impressive. The authors propose that it emulates an RCT. Here are the main findings of the paper. Note that the primary endpoint was a typical MACE of all-cause death, MI, and stroke. First, a larger proportion of patients on the early ezetimibe combo therapy achieved LDL target. The target was less than 55 milligrams per deciliter. Now, it was not that big of a difference, 55% versus 40%. During a follow-up of about 4 years, the unadjusted base incidences were 1.8 per 100 patient years in the early ezetimibe group, 2.8 in the late ezetimibe versus 4.0 in the no ezetimibe group. The big finding is that using the early ezetimibe as the comparator, the adjusted hazard ratio for MACE over 3 years for patients receiving ezetimibe late was 1.14, so 14% higher with late ezetimibe. However, the confidence intervals were 0.95 to 1.41. And for patients not receiving ezetimibe at all compared to those receiving early ezetimibe, it was 1.29. So 29% higher, and here the confidence intervals were 1.12 to 1.55. Now, the absolute risk differences were small. Early ezetimibe to no ezetimibe, it was minus 1.9% or an NNT of 53. Early to late, the risk difference of only 0.7%, so an NNT of 143. The authors did a sensitivity analysis using fractures, which is smart because it might identify patients not treated with ezetimibe due to frailty. This analysis showed no differences in MACE. Now, before I make any comments on this, I want to quote the authors, who clearly have strong feelings. Quote, "When all evidence is considered, we think that the implementation of cholesterol management after an MI, reducing variability in care, and improving prognosis are best served by moving away from a stepwise strategy which only delays the inevitable, i.e. the need for combination therapy for most patients to achieve guideline-recommended LDL levels. Public health is best served by a move toward early combination therapy, which is pragmatically achievable with a combination of high-intensity statin and ezetimibe before hospital discharge." Like I said, the authors obviously feel strongly about early initiation of combined lipid-lowering therapy in your index admission, but I may feel slightly differently. But first, this is a really nice effort at extracting findings from real-world evidence. The reason it's even possible is that there is a sweetheart registry, and you can learn a lot by keeping such registry data. And Northern European countries have obviously invested wisely. The second thing to say is I'm not sure the authors have successfully emulated an RCT, but let's first assume they did. If they did, these are small differences in outcome. It's 2% from early to no ezetimibe. Now, that's not nothing. It's less than 1% in early ezetimibe versus late. For these reasons, I think the best solution would be to simply discuss this with the patient. Maximizers, patients will be all in. They'll go for it. Minimizers may not go for it. I mean, the risk in adding pills with marginal benefits is that you might distract patients from super important things, like not smoking, improving lifestyle, not missing their antiplatelet therapy, and taking their statin. These are the big things after MI. Ezetimibe is not nothing, but it's less important than those big things. Now, that all assumes that the data are not confounded. The editorialists point out that when you look at Table 7 in the supplement, you will find that the mean LDL cholesterol levels at 1 year are nearly identical in the three groups. And if that is so, how can there be significant differences in outcomes? Because we know that in trials like Improve It and Odyssey, the MACE outcomes correlated strongly with the LDL cholesterol levels. So it's likely then, despite their super complex clone sensor weight maneuvers, that healthier patients got put on ezetimibe early. Yet I think there are conclusions can be made to these observations. Here is how I see it. The study may be confounded. The effect size may be exaggerated, which is saying something because the effect size was small to begin with. But still, post-MI patients offer a great opportunity to modify future risk. Post-MI patients and their families are motivated. You have their attention. If the LDL cholesterol is not close to goal and you feel that a high-intensity statin might not get there, you can talk to them about combined lipid-lowering therapy. You can say the effect size is small, but the drug is well tolerated, it's inexpensive, and it's probably real effect. The maximizer patients may go for it, minimizers maybe not. I'm good with either choice as long as the patient is well informed. Now, the authors tell us that there's going to be a PCS combination trial early after MI. This, too, is likely going to find a small effect size. If there are enough patients, the p-value will likely make it. But overall, combined lipid-lowering therapy seems like a highly preference-sensitive decision. All right, next topic is a type of PFA, pulse field ablation catheter, may matter for silent cerebral lesions. CircuitP has published a small but provocative study from a single center in Tokyo comparing post-procedure MRI brain scans with two types of PFA catheters. I'm interested in this issue. Probably you should be too, because we are doing a boatload of PFA left atrial ablations, as is everyone, and more on that later. Because PFA ablation is easier, the threshold to do ablation is lower, and more people are getting this done. Now, I covered a small study of only 16 patients who had de novo PVI and posterior wall isolation because it's an effort that more of us should undertake. 8 patients had ablation with a J&J circular catheter. 8 patients had ablation with a Medtronic circular catheter. If you look at a picture of them, they look quite similar, but lots about PFA differs. For instance, the waveforms of the electrical energy are like a black box. They're just specific to the catheter and to the company. Of course, this wasn't an RCT, but the same operator did the cases. The ACT management was similar, LA dwell time was similar, nearly everything about these procedures was similar. Then they did MRI brain scans post-procedure. Half the patients had white spots in the brain. No patient had a clinical stroke, but the incidence of what the authors call silent stroke, or subclinical cerebral events, was higher in the J&J catheter group. It was 85% versus 22%. The average number of brain lesions, 13 versus 2. Now pause there for a second. Average number of brain lesions, 13. So some people had more than 13 white spots after a PFA ablation. Lesions larger than 10 millimeters, 3 in the J&J group versus 0 in the Medtronic group. My comments are that we should have more work like this. It's not an RCT, but the authors describe extreme care in the use of the catheters, especially the J&J catheter. I don't know any of the authors, but the paper reads like they are quite careful people. But it's a small number of patients. The p-value is fragile at 0.04. Could be noise. But it is worrisome. Now, we can't make definitive conclusions, but we should have more comparative data with these iterations of catheters. Not just the circular ablation catheters, but all types of new PFA catheters. It's one of these issues in medicine that there may be a small effect, slightly more brain lesions, but if any of these leads to future cognition issues, given the raw number of PFA ablations being done, it could be a big issue. Brain scans aren't complicated to do post-procedure. There should be a way to investigate this potential issue, and we as a profession should be interested in it. Next topic is that the Heart Rhythm Society has released a document on establishing centers of excellence for AF ablation. This is a white paper, not yet available to read, but it's authored by 25 international leaders. And the press release has a lot of text that reads like this, quote, "The white paper identifies the need for unified and comprehensive treatment of patients with AF and calls for a state-of-the-art AF centers of excellence to establish a patient-centered, multidisciplinary, integrated model for AF care." And this, quote, "The guiding principles in establishing high-quality guideline-recommended care are systematic patient identification and access, patient-centered care, cost-effective care, procedural quality, integrated multidisciplinary approach, patient and provider education, quality improvement." Now, they say that the paper is published in the Heart Rhythm Journal, but at the time of recording this on Thursday evening, it is not there. But I mention this because it is about time that we have something like this. I don't know about other geographies, but in the U.S., AF ablation is the Wild West. It's a moneymaker for hospitals and doctors, and therefore, low-volume centers are everywhere. A patient with AFib can go to a place and they have no earthly idea if the doctor or team have skills. It boggles my mind that in 20 years of AF ablation, no one is required to keep a procedure log with simple things like complications. And academic centers should also not be exempted from something like this because the experience at famous centers may be affected by the training of fellows. It's necessary, but it's a factor. Reporting outcomes and having some basic processes should be mandatory. For instance, if you have an ablation on an obese patient who has not had any attempts at weight loss, that should fall out as a quality measure. Now, I recognize that report cards have unintentional effects, such as the most complicated patients may not get easy access. It is also true that zero reporting is terrible. I also recognize that efforts to measure quality become susceptible to Goodhart's law. Goodhart's law is one of the most important laws in medicine, and it states that when a measure becomes a target, it ceases to be a good measure. And nowhere is that better shown in healthcare quality measures, which are gamed and manipulated, I'm pretty sure now, worse in quality. Yet still, a modicum of accountability is necessary in AF ablation in the U.S., and it's about time we have some professional society guidance on this. Finally, I was going to close there, but I found the paper published today that was so provocative I wanted to tell you about it. And this has to do with pacing in patients who are undergoing transcatheter tricuspid valve replacement, or TTVR. A Heart Rhythm Journal publishes case series from Emory of 73 patients who had TTVR, and 21%, or about a third, had a pre-existing pacemaker. Well, 19 of these were transvenous pacemakers and 2 leadless, and the real issue is with the transvenous pacers. And in 14 of 19 of these cases, or 73%, the transvenous lead was jailed jailed. 5 patients, or 26%, underwent lead extraction and implantation of a tricuspid valve sparing pacing system or ventricular leadless pacemaker, whereas 1 patient had extraction and did not undergo another device. And after TTVR in this series, 7 of 52 patients developed heart block requiring permanent pacing. 4 patients received the leadless paper, 2 patients had a tricuspid valve sparing pacemaker implanted, and 1 had a lead implanted across the valve. But here's the key finding. During an average follow-up of 10.5 months, complications were reported in 3 of 14 patients with jailed leads. That's 21%. 2 patients required the fractured lead revision. 1 of the revisions was complicated by infection, which resulted in the patient's death. A patient with a jailed right ventricular lead died suddenly 1 week after discharge. I find this a remarkably brave report. More than 20%, 1 in 5 patients with jailed leads had serious, even fatal complications due to lead malfunction. Transcatheter tricuspid valve replacement-related heart block was also common, but it's possible in a way to pace in a way that spares the valve replacement. Now, the authors in their discussion cite other papers in their open access manuscript wherein lead entrapment with transcatheter tricuspid valve replacement has occurred in up to a third of cases. My friends, whatever small impact this podcast has, I remark on this sobering report as a public service announcement. To my structural friends, jailing leads may sometimes be necessary, say, in a frail patient whose risk of extraction is extreme. But the decision to intervene on a tricuspid valve in a patient with a pacing lead ought to be a multidisciplinary decision. It ought to be time out. Let's find the EP doctors. And we can help. We can extract leads. We can place a tricuspid valve sparing system like a leadless pacemaker or a CS pacing lead. An EP doctor might also help you by pointing out the weakness of the evidentiary support for tricuspid valve replacement. We might say, for instance, the benefits of transcatheter replacement were driven by quality of life improvements, and the trials were unblinded. I will close this podcast with the most important phrase in medicine. First, do no harm. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time giving us a rating, write us a review. If you don't agree with something that I said, send me a note, write a comment on the heart.org Medscape Cardiology webpage. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.